Okay, hi. So today I'm going to do a male catheterization. So shout out to Dr. Douly for actually asking me to put this video on. I've done a female bladder catheterization. I wanted to go over the male bladder catheterization with you. So I'm just showing you how I do this particular procedure. And so what you'll need is a catheter pack. Some places don't have catheter packs. Like I feel really spoiled by having a catheter pack to use. Whenever we're doing a bladder catheterization, it's reasonable to expect to have somebody that's assisting you. So I've got Namita helping me out today too, so thanks Dr. Namita for that. I'm just going to empty and open this pack out. So in my last video you may have noticed I use a larger trolley. I'm using a smaller trolley. I've got a lot of confidence in the fact that we'll be able to maintain a sterile field, and I've got some assistance here as well, so that's great. Inside the catheter pack, have a look inside the catheter pack, behind the catheter pack, and they'll tell you what the contents is. So sandwiched in between there is some very useful things for the bladder catheterization. I'll get you to open it up for me later after I glove up. So once I get to this stage, I'm quite happy. As I said, I've got some help and we can maintain a sterile field. What I would do before I did my 3-minute hand wash is I'd open my gloves. I usually put the gloves on the bottom tray, but I'll just put it up here so that you can actually see that I'm putting my gloves on and I'm not going to contaminate. So once I get to this particular stage, I'm happy now to do my 3-minute hand wash. So I'll go off and do my 3-minute hand wash, make sure that my hands are really well dried, and then I'll come and put my gloves on. So throwing the gloves on, just making sure that I don't contaminate anything. Okay, and I'll break my gloves here, that's fine. And that'll happen as well. And then I'll throw this glove on. And now I can adjust. Namita, if you mind just opening that up, that would be fantastic. Thank you, I'll take that. Okay, so the catheters have a little fenestration on it. Some people like to keep the catheter inside the plastic, and I don't like to do that because I think the plastic is very limiting in terms of the volume it can accommodate and when a patient has a full bladder. Okay, so at the moment I'll just gather my equipment and set up my tray. So you can see that there's a fenestrated sheet. I'll go over the fenestrated sheet. They've given us a flush. So this is a water for injection flush to inflate the balloon. So we inflate the balloon with water for injection, not normal saline. I've also got some lubricant here as well that's specifically made for males. And we've got some normal saline that they've given us that we can use to clean the area with. Okay, they've given us some lubricant here, just in case we need some lubricant for females, but we're gonna use the male lubricant for this particular procedure. And they've also given us a dressing tray as well too. I'll get my flush ready. Okay, I'm not going to go over indications or contraindications for bladder catheterization. I just really want to show you how I actually do this procedure and give you a couple of tips and tricks as well. So we need to expose the patient and put this fenestrated sheet down. So hint is the fenestrated sheet is actually quite large, so I like to step back and then don't shake the sheet. People just don't like that from an infection control point of view. So just unfold the sheet like this. Okay, and you'll notice that sheets have a hydrophilic and a hydrophobic side. The hydrophilic side, the rough side, I like to put up most of the time. There are some times where I like the smooth side up, but for this particular case, I'll do that. Okay, sir, excuse me. And so then we actually put the drape on. And what we do is that we really need to expose the penis, and the scrotum obviously isn't part of the procedure.
You need to separate the meat from the tube edge.
Okay, so I'll get that happening here. And I can now work out my sterile field. So what we're doing is I'm getting 3 gauze, saline soaked gauze prepared for the procedure. Now, if the patient has a foreskin, it's important to note if the patient is unconscious and you pull the foreskin back, you've got to put it back the way you found it. Otherwise, there are horror stories of necrosis and everything else. So listen to your mothers, guys, and put things back the way you found it. Okay, it's a really important thing to do. Now, this drape here, this random drape here, I'm going to use this drape for something else. as well. Okay, so I think I'm ready to go now with my cleaning. Now that I've got the patient prepared, I want to clean the area. With all my procedures, again, I like to put an imaginary line. This is my dirty side and this is my clean side. Looking at the transfer across, I want to clean the area around the meatus. I'm happy to drop the contaminated gauze at the foot on the drape. That's fine. 1, 2, 3. Okay, I'll dispose of that as well. Okay, so now what I'm going to do is I'm going to take the syringe with the lubricant on it. Okay, so the syringe with the lubricant has a different tip on it. It's not compatible with your intravenous devices, and it's made specifically for male bladder catheterization. The tip is a bit larger, it's a bit longer, and to put the anesthetic in, it's basically lignocaine mixed with some KY gel. I do like to hold the patient's penis like this. So once you actually put the lubricant in and you inject the area, you'll notice that my right hand is still uncontaminated. It's only touched a sterile syringe, okay? I like to hold it in there for about 30 seconds to let the anesthetic work. If you take the syringe and the applicator out, the gel will come out, okay? Because, so that's the reason why we hold it there. We gotta basically keep the gel and the anesthetic contained in that one area. Once we remove it, just drop it. Once that's ready to go, the gel usually starts to seep out. So what I want you to do is I want you to have a look at how I bring the catheter over to the patient. So I'll have the tray, I'll put the end of the catheter inside the tray, and I'll bring the whole tray over. So now I've actually got a receptacle that's going to enable us to accommodate some urine that starts to come out, and then we actually start to thread the catheter in. Okay, so it's pre-lubricated. You usually know when you hit the prostate because it stops. So what I like to do, I just found that if I point the penis towards the roof and lift it up, it somehow opens the aperture and allows us to bypass where the prostate is. And again, remember, once we actually start getting some urine, which would be about now, we push it in about 1 inch further. So avoid the temptation of pushing it in further than 1 inch, because there are stories, some horror stories about the catheter going along the lining of the bladder and then coming back out into the urethral opening, and therefore causing trauma when we blow up the balloon. Again, if the patient is awake, I like to look at the patient's face and see whether they start screaming once we inflate the balloon, and this patient clearly isn't. And at this particular stage, we would get the assistant to, there's a catheter, thanks Namita, there's a catheter thing there. And so the procedure's over. I'll gladly pull this back until it stops, and Dr. Namita can actually attach that now. So the procedure's finished now, and we can start tidying up, and Namita can actually show us how we actually secure the catheter on a patient's leg, and I'll hand that over. Thanks a lot. Now, in the event that we can't get the catheter into the patient, there's a number of reasons why we can't do that. It would be some prostate hypertrophy, or sometimes there might be a false passage in there. So if there's a false pouch and we couldn't get the catheter in, what we do is we leave the catheter in situ and get somebody else to come in and do another attempt of a catheterization with that still in situ. That's the way that we've been doing it. And it looks pretty bad and it looks pretty painful, and it probably is. If you just have a look, we've actually been able to secure the catheter with a particular dressing here, and so the patient will be able to mobilize, and the procedure's over. We cover up the patient, and thanks very much. Okay.